talk will start. I'd like to welcome everybody to this pep talk. Please mute yourself, but always show your video picture. Sign in your name, your Facebook account, or email address in the chat box. Please include names of companion attending. Use the chat box to ask questions and make comments while the pep talk is on. There will be group pictures at the start and end of the pep talk. Please show your face in the video during the group picture taking. As a reminder, please take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. The link has been placed in the chat box by Abet. Okay. The certificate will look like this. As a reminder also, those who have passed 50 OLETEs and will get 50 OLETE certificates, they are entitled to one free voucher for ROJoson telemedical consultation. Let's now have a group picture taking before we start the pep talk proper in 2 minutes. Please show your video. Show your face. Okay. 1, 2, 3. 1, 2, 3. Okay. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in the Medical Management of Goiter, Part 1. This is part of the health disorder course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities of the medical management of goiter. As I said, this will be part 1. There will be 3 parts. In part 1, the contents will be what is a goiter, what are the common types of goiter, what are the causes of goiter, and how common are the goiters. In part 2, we will be tackling clinical diagnosis or when to suspect goiter, the presence of goiter, and how to diagnose it, and paraclinical diagnostic procedures for goiter. In part 3, we'll be talking about treatment for goiters and health restoration and maintenance after being treated for goiter. Some definition of terms in the title and the limitation of coverage of my talk. The word fundamental will be used to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced or additional information in the future. Generalities to mean general statements of information, not covering specifics and details. Medical management means diagnosis and treatment being done by physicians. What is goiter? There are a lot of definitions given to the word goiter that often leads to confusion among the lay people as well as the health professionals. The definition can be as the word goiter was used first, long time ago, before, and as it is used now. Allow me to clarify on the concepts of goiter used by other people that have created confusion, and then allow me to give my 2 cents worth on the concept of goiter that I think will be simple and of practical usefulness in medical management. First of all, goiter refers to something wrong with the thyroid gland. Okay? And the thyroid gland is the butterfly-shaped organ located in the front and on the base and central part of the neck. The thyroid gland is a vital organ. When you say vital, it's one that is needed to survive. So you cannot live without a thyroid gland. This thyroid gland regulates metabolism, growth, and development in the human body. The thyroid gland makes, releases, controls thyroid hormones that control the metabolism. Metabolism is a process where the food taken into the body is transformed into energy. This energy is used throughout the entire body to keep many of our body systems working correctly. There are two concepts of goiter used by other people. One concept is the connotation that it is benign, not a malignant, not a cancer of the thyroid gland. The backstory here is that there was a time iodine deficiency was a very common cause of thyroid enlargement. Thus, this connotation of goiter referring to the iodine deficiency goiter, and thus the connotation that it is benign. The other connotation is that goiter is an enlargement of the thyroid gland. In the internet, the word enlargement is commonly used to describe the presence of a goiter. But enlargement has a connotation that the whole thyroid gland is enlarged or increased in size without nodules. In reality, abnormalities in the size of the thyroid gland or in the thyroid gland that connotes a goiter, goiter is present, can be of two types. Now, the abnormalities, either enlargement or the presence of nodules. Both can present as an abnormality of the thyroid gland or the goiter, but they have different implications in terms of possible causes, as we shall see later on. So we have to differentiate enlargement from nodules. At this point, my 2 cents worth is to just define goiter loosely as any disorder in the thyroid gland. Okay? Any disorder in the thyroid gland. I saw one site that defines goiter as an irregular growth of the thyroid gland rather than enlargement of the thyroid gland, to which I initially appreciate and prefer. However, on a second thought, I said I'll just stick to the goiter as any disorder of the thyroid gland, as not all goiters will have enlargement or irregular growth on that gland for that matter. So one can have a goiter in which there's still no physical growth or enlargement of the thyroid gland, and yet it is producing abnormally high or abnormally low levels of thyroid hormones, in which it is still called a goiter. To repeat my 2 cents worth on the definition of goiter, it is any disorder, whether it's a medical condition or a medical disease in the thyroid gland. Okay? So it is any disorder in the thyroid gland. To differentiate medical disease from medical condition, a medical disease is a more specific term than a medical disorder. A medical disease is characterized by specific signs and symptoms that identify an abnormal entity in the body. There is strictly speaking, there is a disease present. A medical disorder is any abnormality or disruption in the normal structure and or functions of the body, but not pinpointing to a specific entity yet. So sometimes a medical disorder is not automatically a medical disease. A goiter can be one that has diffuse enlargement. It can also have nodules, or it can have no changes in the structure of the gland, but there is abnormality in the secretion of the thyroid hormones. So that's a summary of what is a goiter. And a goiter can also be benign or malignant. Not always benign. It can be malignant. Now let's go to the second question. What are the different types of goiter? Goiter can be classified into several categories by clinical presentation, by general categories of the disease, and by the names of specific diseases. By clinical presentation, okay, the thyroid gland has both structure. This is the butterfly-shaped organs at the front, base, and center of the neck, and it also have functions because it secretes thyroid hormones. So it can have abnormality in both structure and function, either alone, structure, or both in combination. There are a lot of classifications, categorizations, and which also have led to a lot of confusion among doctors and among patients. Okay, this is one of the classification. So one classification is you look at the abnormality in function. When you say function, it's in terms of secretions of the thyroid hormones. If it's over-secreting, if the thyroid is over-secreting, then you call it hyperthyroidism. If it's under-secreting or less than the normal, then you call it hypothyroidism. If it's normal, if there's no abnormality in the secretion of the thyroid hormones, we call it euthyroidism. Abnormality in structure, it's another type of clinical presentation. Okay, it can, as I said, it can either be enlarged, in which the whole thyroid gland is increased in size, or there are nodules. Okay. So the other one is a combination of abnormality in both structure and function. So this is one of the categorization on the different types of goiter. So when you have abnormality in the thyroid gland, you call it goiter right away. So a goiter can have, there is such a thing as goiter, but there is no structural abnormality yet, no enlargement, no nodule, but there could be over or under secretion of thyroid hormones. So this is one situation. The other situation is that you have a disorder of the thyroid gland in the form of structural abnormality, either enlargement or nodule formation, but without over-secretion or under-secretion of thyroid hormones. Okay. Another setting would be you have a goiter, a disorder of the thyroid gland with structural abnormality, okay, but with, the other one, the second one is without, but this one is with over-secretions and under-secretions of thyroid hormones. So another classification is goes this way: diffuse toxic goiter, okay, meaning the thyroid gland is diffusely enlarged, okay, and then toxic refers to the presence of hyperthyroidism, okay. And then diffuse non-toxic goiter, diffuse enlargement, but non-toxic means without hyperthyroidism. When you say without, it could be the patient is in euthyroid or in hypo, okay. So in this classification, it gives priority on the hyperthyroidism over the hypothyroidism. Nodular toxic goiter means there are nodules, and because of the word toxic, there is the presence of hyperthyroidism. Nodular non-toxic goiter, nodules without hyperthyroidism, but there could be euthyroidism and hypothyroidism. So it's a combination of the functions and then also the structural abnormality being described here. So the definition of diffuse enlargement, okay, this is very important. Okay, the definition is that the major lobes, okay, there are two major lobes, the right and the left lobes, okay, are almost symmetrically, okay, it's not perfectly equal, but it's almost symmetrically enlarged or increased in size, and there are no palpable nodules. So in the presence of nodules, okay, you call it nodular goiter already, okay, nodules or masses. So the other type of categorization or classification of goiters will be, you use the general categories of the diseases, okay, very simple, whether cancer or not cancer is present, whether hyperthyroidism or hypothyroidism is present. Now, the other type of categorization is by the use of names, which is very, very complicated. Okay, but let me just give you an idea. Okay, so these names are officially published by the World Health Organization, International Classification of Diseases. So this is supposed to be the one being the so-called standard, okay, being followed by almost all countries. Okay, and the names of the diseases can also be popularized by thyroid experts. Okay, which, as I said, it creates it's very complicated, and it creates a lot of confusion because all these thyroid experts may not jive with each other. Okay? So samples of names of thyroid diseases, this derived from the WHO ICD-10, as well as I inputted some of my thoughts. Okay, congenital iodine deficiency syndrome, iodine deficiency goiter, endemic iodine deficiency goiter, diffuse non-toxic goiter. An example will be, another term will be diffuse colloid adenomatous goiter, nodular non-toxic goiter. Examples will be colloid cysts, solitary colloid adenomatous nodules, and multiple colloid adenomatous goiter. Others will be hyperthyroidism. There are two types of hyperthyroidism. One is the so-called Graves' disease, in which usually this is accompanied by bulging eyes. And then the other one, without the bulging eyes, is just simple hyperthyroidism, so which we call it unspecified, and hypothyroidism. There's such a condition as thyroiditis, okay, acute due to an acute infection, bacterial infection, subacute usually due to autoimmune disease and chronic thyroiditis. Then benign tumors or neoplasm of the thyroid gland. Examples will be follicular adenoma, Hurtl cell adenoma. Okay. Then cancers, papillary thyroid cancer, carcinoma, follicular carcinoma, Hurtl cell carcinoma, medullary thyroid carcinoma, anaplastic thyroid carcinoma. So these are the terms that you will be encountering when you have the problems in the thyroid. So I try to simplify the categorization, okay, and classification by putting it this way. When I manage my patient, I find this classification useful. Okay, so DTG means diffuse toxic goiter, DNTG, diffuse non-toxic goiter, NTG, nodular toxic goiter, and NTG, nodular non-toxic goiter. So after examination of the patient, I can come out with this classification, okay? But this is not yet the exact diagnosis. After that, okay, so I mentioned this already, the how we define diffuse, DTG, DNTG, diffuse enlargement. Almost all the two lobes are symmetrically enlarged. But if there are nodules, then you call that nodular goiter already. Okay. So example here, normal size thyroid gland. This is an illustration of diffuse goiter. The two lobes are almost symmetrically enlarged, usually not perfectly equal. Okay, this is another illustration. This dotted line shows the normal size of the thyroid gland, and then there is enlargement of the two lobes. Okay, so this is diffuse enlargement. Nodular goiters are those in which there are nodules, and then one lobe is extremely or has a let's say 2 times or 3 times enlarged than the other one. Because in diffuse goiter, you call almost we define diffuse goiter as the two lobes are almost symmetrically enlarged. But in nodular goiter, if you don't feel a nodule, but one lobe is 2 times, 3 times, 4 times bigger than the other side, you still call that nodule because chances are there are nodules inside, which causes the enlargement of one lobe. So the difference between diffuse and nodular, okay, this is symmetrical enlargement. Non-symmetrical enlargement becomes automatically nodular goiter. Okay. So this classification is very important in the study, in the diagnosis, evaluation of goiter. As I said, it's very important because diffuse enlargement, like this one, okay, the implications or the connotations is that you can have hyperthyroidism or hypothyroidism. Okay, you have to suspect these two, but at times it can be euthyroidism. Okay, so it all depends on the associated symptoms and signs. Then, if there are nodule formation, we start talking about whether there's cancer or no cancer. Okay, so if there is diffuse enlargement, you talk of function disorder. For nodule formation, you talk about cancer or no cancer. So the common diseases that I usually diagnose, which I can recognize clinically even without laboratory tests, okay, and which are relatively common in the community are the following: Graves' disease for special type of hyperthyroidism, hyperthyroidism, hypothyroidism, acute thyroiditis, chronic thyroiditis, okay, malignant nodules or thyroid cancers, papillary carcinoma, follicular, anaplastic medullary. And then for the non-malignant nodules or conditions, you have colloid cyst, colloid adenomatous nodule, multiple colloid adenomatous goiter, and another one, part of this family of diseases of conditions will be diffuse colloid adenomatous goiter. Currently, from the past up to now, there are no uniform answers or lists among physicians and medical organizations on the different types of goiter. So medical organizations, thyroid specialists, and practicing physicians have different listings. Okay. Even myself, I have a different listing. Okay. So this causes a lot of confusions among medical practitioners and patients. If there are different terminologies used by the doctors, by the physicians, by everybody, even the pathologist, okay, so just settle for this thing, okay, to simplify things. So just answer the question whether the medical condition or medical disease involving the thyroid gland is a disorder of functions or a disorder of structure or both. This will simplify matter. Okay. Number 2, whether there is hyperthyroidism or hypothyroidism or euthyroidism, meaning normal. Okay. Whether there is malignancy or not. So let's now go to the causes of goiter. In general, the risk factors include the following: genetic predisposition, environmental influence or factors like lack of iodine intake, excessive exposure to radiation to the neck, stress, and other things. I like to take a note here, to put down a note here. A lot of goiters have no definite known causes, except for the lack of iodine intake and then probably excessive exposure to radiation on the neck. Okay. So, but for the more specific causes, for the specific diseases like iodine deficiency goiter, it's due by the term itself, is due to the lack of iodine. That's why there is enlargement of the thyroid gland, goiter. Colloid adenomatous goiter, the exact mechanism we still don't know, the exact cause, but it could be due to physiologic changes and degenerative condition. Cancer, we know the bottom line is it's due to a genetic mutation, okay, with predisposition, okay, and genetic predisposition, and some with the history of a long duration of radiation exposure to the neck, okay. And then chronic thyroiditis could be due to an autoimmune disease, acute infection, thyroiditis infection, hyperthyroidism, autoimmune disease, and hypothyroidism, usually due to iodine deficiency or some physiologic causes. So except for iodine deficiency goiter, which is due to lack of iodine intake, which can be prevented, for the other diseases, one, nobody can predict when one is going to have a thyroid disease, unfortunately. And two, the causes are realistically difficult to identify and to control. So the healthy lifestyle with adequate iodine intake is the best bet against thyroid diseases. However, there's still a percentage that one cannot prevent a thyroid disease from occurring, even if there is a healthy lifestyle. So how common are the goiters? The last question. Based on my personal experience in my medical practice, the more common ones are those with structural abnormality compared to those with pure functional abnormality, such as hyperthyroidism and hypothyroidism. The proportion of 95% to 5%, 95% for the structural abnormality. It's more common to have benign condition compared to cancers. Again, the proportion is about 95, fortunately, 95 benign, 5% malignant. Okay. So iodine deficiency goiter is practically non-existent nowadays because of iodine intake and iodine fortification of foods. Okay. So what's remaining is that you have colloid adenomatous goiter, which is very common, most common, okay, about 90%. And then cancers of the thyroid gland, about 5% only, okay. Then hyperthyroidism, about 3%. The rest are about 1% chronic thyroiditis and hypothyroidism. So summary and takeaway in this part one: what is goiter? What are the common types of goiter? What are the causes and how common? Okay, let me repeat. A goiter, just define goiter as any disorder of the thyroid gland. And it's not referring exclusively to a benign disorder. It can be malignant. And it's not referring exclusively to a diffuse enlargement. It can include a lump or a nodule formation. What are the common types? So many types in terms of disorders, in structure and functions, and in terms of specific diseases. That creates a lot of difficulty in remembering and also confusion. Okay, but basically, you just try to remember this: diffuse enlargement. The implication there, if there is a diffuse enlargement, you have to suspect hyperthyroidism. Okay, which is quite common compared to more common than hypothyroidism. But a lot of times it can also be euthyroidism. And then if there's a nodule formation, you start suspecting whether it's cancer or not. And what are the causes of cancer? As I said, the risk factors are genetic predisposition and environmental influence. And then, okay, a lot of goiters, you have to take note of this, a lot of goiters have no definite known cause. And how common are the goiters? Fortunately, majority are not cancers, and majority are colloid adenomatous goiter. only 5% are cancers. So takeaway in relation to patient empowerment, be always in touch with reliable medical information on the fundamentals and generalities in medical management of goiter. Knowledge is power, it gives power. Use the 4Ks of patient empowerment, kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in medical management of goiter. So with that, I end my talk on part 1 of this series, Fundamentals and Generalities in Medical Management of Goiter. I hope I have empowered you to have a better understanding of the fundamentals and generalities in the medical management of goiter in this part 1 series. So as a reminder, before we go to the open forum, please take the OLETE for Mastery of Learning, get a perfect score to get this certificate. And then 50 OLETE certificates will entitle one to a voucher for ROJoson telemedical consultation. We are now on, this is the PEP Talk number 34 already, okay. So let's now have a group picture taking before we start the QA and interactions. Please turn on your video, please show your face. Okay. Okay. Ready? Are you ready to show your face? Okay. 1, 2, 3. Okay, may pahabol si Chuchi. 1, 2. Chuchi, go a little up. Yan. 1, 2. 1, 2, 3. Okay. Okay. The floor is now open for questions, interactions, suggestions, comments, etc. I see a lot of new faces today. Okay. Any questions? How many have thyroid concerns right now? Okay. So.
Doc, I have a question.
Sure. Okay. Isa, yeah. Okay.
My sister, as I told you about her, she's in LA. She has the same problem as mine, multinodule. Then last week, she was diagnosed, her lab test showed suspicious nodules. So she underwent aspiration 3 days ago. She got 3 extracts. And then earlier, kanina, she was called by Kaiser. Ano daw, ano siya? Benign ang findings. Does it mean that ganun din pagka, hindi ba hereditary or the same genes kaming dalawa, most probably, ganun din sa akin, benign din.
Okay. Okay. Okay, the rules of hereditary, the rules of, okay. So, okay, when you say hereditary, okay, chances are if you in terms of diseases, it could be the same, no? Bigger chance the same, but not 100%. Okay, not 100%.
But you already, during my previous consultations with you, you assured me that it was a multiple colloidal adenomatous goiter.
Yeah. Okay, but let me go back. You're talking because your question is whether you will have the same. You assume now. So as I said, the rule here is that it's if you have the hereditary factor present, then bigger chance it will be the same. Okay, but it's not 100%. Okay, so in the end, it depends on what is the real situation in a particular person. example, yours is multinodular. Suppose in one of your sister, okay, your sister is also multinodular, right? Okay, so but you could have another sister who will present with a single nodule, di ba? Okay, it's possible, no? So and then baka may neck node. So it could be that the other sister, if you have another, I don't know if you have another sister, just for the sake of discussion. Okay, so if you have another sister, you can have another sister with different presentation, no? Okay, so solitary nodules with neck nodes, no? Okay, so but it all depends on the evaluation of a particular person. Okay, what he has, just like personality of persons are different, di ba? Okay, personalities are different. Okay, so yours, so as I said, as you mentioned, I gave you a diagnosis of multiple colloid adenomatous goiter, right? Tama? Okay.
Yes.
Okay. So, do you know what is the term used by the Americans?
No.
That's what
She did not tell me.
I'm trying to point this out in this lecture. There you'll be confused as a lay person, no? Because there's so many terminologies, no? Okay? Iba-iba, no? Okay? Iba-iba, no? So I usually I still hold on to my style of way of doing things by trying to be more specific in my diagnosis. Kasi in the WHO classification, they just call it multinodular non-toxic goiter. Okay, so it's not very specific to a particular disease because there are a lot of multiple nodules presenting with different diseases. Okay, so but if I tell you that what you have is multiple colloid adenomatous goiter, okay, it's very specific. It's benign. Okay. It's benign, it's a benign condition, na? Ganun. Okay? So yung sa'yo, okay, multiple colloid adenomatous goiter. Yung sister mo, okay, as I said, chances are they'll be the same. And then, especially if it's multiple, okay, okay. So tell everybody, mas malaki yung chance na benign if it's multiple. Kasi takot kayo kung multiple, di ba? Okay? Okay? So baliktad, ha? Okay? So kung solitary, mas delikado. Higher chance of a danger, mas dangerous kung solitary lang, isa lang, no? Compared to multiple. So your sister has multiple, di ba? So maganda pa rin ang chance na hindi siya cancer, no? Okay. So don't ask me why I didn't biopsy your neck, huh? Did I biopsy your neck already?
No, not yet.
Okay. Okay. So we have different styles, di ba? Okay. Any more questions?
Thank you, sir.
Okay. Somebody's raising his hand. Okay. And okay. Anong pangalan? I-unmute sarili mo.
Magandang tanghali sa inyo lahat, Doktor.
Yeah, identify yourself para alam natin.
Ako po si Paterno Constantino.
Okay, Paterno Constantino.
Apo, asawa po ni Raquel.
Yeah. What's your
yung Omicron virus ho ba ay mabilis makahawa sa may mga thyroid? Hello po.
They said that if you have comorbidity, mas mataas ang chance na magkakaroon ka ng complications from the virus.
Omicron, yes.
Okay? Mas mataas na ang chance. Pero kung stable naman yung tinatawag na, let's say, thyroid condition mo, usually hindi rin. Hindi gaano, na? Okay? Hindi significant, na? Okay? Okay?
Okay po, Doktor. Maraming salamat po.
Okay. Any more questions? Yeah, Chuchi. You're recognized, Chuchi.
Sorry, I was late, so I missed the first part of the talk. But anyway, I'm very interested in this talk because my driver has goiter. Pero yung first manifestation niya, I think, was hindi makalakad. There was something wrong with his legs. Na there were times na hindi siya makapag-drive kasi hindi makatayo. What do you think that is related? Because now it was already established na meron na siyang goiter because malaki na dito. But
Okay.
is that how?
Okay, how to evaluate? So two symptoms. Neck symptoms, neck sa thyroid, sa goiter, no? And then those difficulty in walking, no? Okay. So we try to determine whether there's a connection. Okay.
Yes.
The only connection that I can think of is if you have, this is without examining your driver yet, huh? Okay, just theoretical, huh? The only connection that I can think of, if there is sabihin natin, may metastasis, no? Okay, metastasis to the leg. Okay, so kasi you can have a thyroid cancer which can spread to the leg, di ba? Okay, then it will cause some pain, some difficulty, no? Okay, so that's the only connection that I can theoretical. So, but in the end, we really have to examine the thyroid muna. Okay, so can you usually see your driver, right? Okay.
Yes,
so,
yes. Well, after the leg problem, he started having tremors.
Tremor, okay.
So when we had him check for his yung blood test, masyadong well, that's where they found out that he has hyper.
Okay, tama yun. When you have tremors, that's a cue for hyperthyroidism. Tremors, no? Okay. Aside from weight loss, sudden weight loss, no?
Yes. Now he's very, very thin already.
Okay. So if you look at his thyroid gland, so you really have to assess muna ito, yung neck niya. Okay, by in the end, it will be by palpation. Okay. Yung symptoms can give you some clue. As I said, yung if he has his symptoms of tremors, you start thinking, baka hyperthyroid ito. Ganun, di ba? Okay, but you have to really check, no? Okay. And then so anong sa tingin mo sa driver mo? Okay, you missed the first part or second part, no? The second part is actually whether it's enlarged or nodular. Yung leg niya parang swollen, pantay ang laki.
Pantay, yes.
So enlargement, okay?
Yes.
Okay, kasi iba yung bukol na one solitary ganon.
Yes.
Implication. So enlargement siya. So you start thinking
pareho.
You start thinking of hyperthyroidism. That's the most common. Okay? So in the presence of tremors, most likely meron siyang hyperthyroidism. Okay? So
that's already goiter. Or not necessarily.
Goiter, as I said, if you see any abnormalities sa thyroid gland, enlargement or nodules, goiter na lahat siya.
Goiter na, okay.
Yeah, goiter na, okay? Then, the next thing is to do is just to differentiate anong klaseng goiter, no? Okay? So, maraming klase, no? As I said, kanina, you told me just the limping lang, yun lang data mo, no? So kung yun ang i-connect ko, cancer, di ba? Okay? Pero bihira yun. So we really have to evaluate the neck. Pag sinabi mo may bukol, may isang let's say santol size o kaya calamansi size, no? Pwedeng cancer, di ba? Kasi nodules, okay? Pero sinasabi mo parang swollen siya, enlarged lang. Okay? Kung enlarged, we start thinking baka hyperthyroidism, na? And then we check for other data na. Okay? So kung may tremors, okay, another point for hyperthyroidism, na? Okay, in favor, na? And then, i-check mo yung heart rate niya. Okay? If you can check it. If you don't, kung may palpitation siya, ano na lang. May palpitation ba siya? Does it complain to you, palpitations?
Yes, yes.
Okay. So,
Also,
usually, mabilis ang heart rate ng mga may hyperthyroidism.
mabilis.
Then, the other one is yung mata niya, lumuluwa ba?
Hindi naman.
Okay. So, hindi siya, kasi there are two types of hyperthyroidism. Yung tinatawag na Graves' disease, may pangalan Graves' disease na may lumuluwa. No? Okay. Yung iba naman, wala. No? Okay. Just simple hyperthyroidism. No? So, and then, you have a blood test already. So, it's confirmed. It's confirmed. No? Okay. So, yung limping niya, I suppose it could be due to the hyperthyroidism. Limping niya both legs o isa lang?
Oh, actually, it doesn't come very often. Paminsan-minsan lang.
Okay. Non-specific na siya. Baka hindi siya related. No? It's not related. No? Okay. So what he has at the moment is sure na meron siyang hyperthyroidism.
Right.
No?
Okay.
Okay?
Okay.
Okay.
Thank you, Doc.
Good for bringing that example, that situation, that case for enlightenment to everybody. No?
Kasi mahirap ho malaman kung ano ba talaga ang sakit nito. I thought in the beginning, nag-arte lang. Hindi naman pala. Sabi ko, baka umaarte ka lang, ayaw mo mag-drive. So anyway.
After this pep talk, kaya mo na mag-diagnose.
Okay, thank you po.
Any more questions? Any more? Ladies, anything on the chat box? None.
Wala po.
Oh.
Wala. Dok, ano ho yung unang-unang sign or symptom ng goit? Kunyari, layman ka, wala. Kasi alam, syempre dito, syempre sa neck. Meron ho bang, pag may goiter ka, automatic lalaki yung ano mo, yung may bukol, may mag-enlarge, or pwede ring sa loob yung ano?
One, basta you start with the thyroid gland, no? Normal yun, normal thyroid gland. Now, usually hindi siya nakikita, no? Okay? From the surface. Hindi mo makikita yon, di ba? Okay? Hindi mo na-outline. And then, pag kinakapa mo, usually hindi mo rin makakapa kasi maliit, di ba? Okay, small one. Okay? So the moment there is some abnormality sa thyroid gland, okay, it can, as I said, there are two abnormality, structure means yung korte niya, no? Yung anatomy niya. The other one is function.
Function.
Okay? Kung nauna kung ang abnormality is function, no? So sa early stage, wala ka pang makikitang enlargement ng okay? So nagsisecrete na siya ng sobrang daming thyroid hormones, but hindi po nakikita. Okay? Okay? But over time, kung di na-control siya, let's say 1 year, 2 years after, no? Hindi mo na-control yung over-secretions niya, lalaki, makikita mo na, lumalaki na yan. Parang yung sa driver niya, ni Chuchi. No? Malaki.
Okay po.
So, kitang-kita na. No? So, as I said kanina, we don't know what disease dadapo. Di ba? Kanina sinabi sa lecture. So, pwede ding bukol. No? Okay? Pag bukol, again, it depends on the stage. Kung maliit pa lang, hindi mo mapapansin. No? Okay? Unless talagang kakapain mo. No? Okay? Now, kung pag malaking-malaki na, let's say 1 inch, 2 inches big na, okay? Makikita mo na. Okay? Sa leeg. Makikita mo yung mapapapa mo sa leeg. No? And then the clue that you're dealing with the thyroid is yung swallowing. Pinapaswallow natin. Okay? Okay? Yan ang trick doon. You ask the person to swallow. Kung anything that moves with swallowing up and down, most likely meron siyang problema sa thyroid. Kung meron siyang problema sa thyroid, automatically we call it goiter. Goiter na. Okay? Then we subclassify it into different types of diseases. No? So
Okay.
sa Pilipinas, as I said, the most common is still bukol. So makikita mo as ang tanong mo kung ano yung presentation, usually bukol. Either enlargement or yung isang bukol o maraming bukol. No? Okay?
Okay. Thank you, Doc.
And it all depends on the sizes. Parang yung kay isa, maliliit lang, multiple, di ba? Maliliit kay isa, di ba? Okay.
Doc, how do we know if
Thank
there's
you po.
oversecretion?
Ha? Ano?
How do we know if there's oversecretion of hormones? Anong indication na mayroong oversecretion of hormones?
Ayun nga, kung mag-oversecretions, hyperthyroid, di ba? Okay?
How do we know paano kung mayroon ng oversecretion?
Kaya nga, I'm just starting with the presupposition, no? Okay? So hypersecretion of thyroid hormones, no? Diba? As I said, yung thyroid hormones are responsible for metabolism, no? Okay? So pag sobra, hypermetabolic ka, no? Kaya talagang mauubos yung energy mo diyan, no? Okay? So sudden weight loss, okay? Sudden weight loss is one of the symptoms of hypersecretions, hyperthyroidism, no? Okay? Then the other one is tremors. Tremors, okay? So in answer to your question, how do you know? Diba? How do you recognize? No? Okay. The other one is yung may bulging eyeballs. No? Okay. And then the other one is enlarge yung niya, thyroid niya. Enlarge, hindi nodule. Ha? Okay.
Dok, hanggang ngayon kasi iniisip ko noon, nagkaroon ako ng sudden weight loss before I consulted with you. Nagkaroon ako nag-reduce yung weight ko. And then after ng mga year after ako nag-take ng Tidine na pinatake mo sa akin, na-recover ko na ulit yung weight. It has something to do with kaya yun?
No. Yung sudden weight loss, that's the first cue, but you have to investigate further. No? Okay? You have to investigate. No? So hindi porke sudden weight loss automatically 100% hyperthyroidism. No? Okay? As I said, it's just a first cue, first suspect. No? Then you have to investigate. No? Okay? Kasi then pag kinapa mo, hindi mo malaki, baka hindi, di ba? Or baka starting lang, no? And then kung may duda ka, you can have a thyroid function test done. Kung normal, so yung sudden weight loss mo is due to other causes. Baka due to stress, due to other factors, no? Okay?
Kasi after 1 year kung mag-take ng Tidine, bumalik na ulit yung nag-gain na ulit ako ng weight.
Pero non-specific yan, non-specific. Kasi I think it was documented that you don't have hyperthyroidism, di ba?
Okay.
Okay. Okay.
Doc, may isang question po from Jacqueline Tong.
Okay.
When you do a blood test to confirm goiter, is it values of the T3, T4, and TSH that you are looking at?
Yung T3, T4, TSH are the so-called thyroid function. Function, huh? Remember that function test, no? So you're trying to check whether there is a normal amount of secretions of the thyroid hormones or there is hypersecretions, meaning masyadong marami, okay? Or under or below normal. So hypothyroidism, hypo, no? Okay. Now, yung T3 and T4, these are the so-called thyroid hormones, yung pinaka-hormones being secreted by the body, by the thyroid gland, no? FT4, FT3, ganon, no? Yung TSH is another hormones, but it's secreted by sa brain, no? Sa brain, no? So it's kaya tinawag ng TSH stands for thyroid stimulating hormones, no? Yung hormones that's coming from the brain stimulates the thyroid. No? Okay? Okay. So kung mataas yung TSH mo, ibig sabihin na kulang kasi nire-regulate ng ano mo yung brain mo, yung thyroid gland. So kung mababa ang sinisecrete ng thyroid gland mo, no, let's say mababa ang T4, T3 mo, so hypo ka, so ang tendency yung TSH is tataas. Tataas kasi talagang kasi may automatic control yan eh. Sasabihin niya sa thyroid gland, mag-produce ka pa ng thyroid hormones, mag-produce ka pa, no? Okay? So baliktad yung interpretation no. So T4, T3 kung mababa at mataas yung TSH, ibig sabihin hypothyroid ka. Okay? Okay? Kung mataas yung T4, T3 mo, mataas, per se, it's already hyper. No? Pero kung idadagdag mo yung TSH for the interpretation, then yung TSH should be low. Okay? Baliktad. Kasi parang feedback mechanism siya eh. No? Okay? Automatic control siya. No? So the way to interpret that, look at the T3, T4 muna. No? Kung talagang mataas, no? Kasi kung sa mga laboratory, may mga errors din yan. So that's why you use the TSH to complement it. No? Okay? So kung ang picture ay hyperthyroidism, so if you have hyperthyroidism, yung T3, T4 mataas and then TSH mababa. If you have hypothyroidism, mababa ang T3, T4 mo and then you have elevated o mataas yung TSH mo. No? Ganon. Okay? So a word of caution lang kasi dito sa Pilipinas, even abroad, no, they rely too much on TSH because it has been taught that don't do T4, TSH, don't do T3, T4 anymore, just rely on TSH. No? From my experience, maraming mali din ng laboratory sa TSH. No? That's why I still go for T4, kahit not some T4 lang without T3, T4 and then TSH. No? That's the current problem in the Philippines. Yung kasi yung mga doctor, endocrinologists, they rely too much on they believe on the TSH na pwede na, no? So, but from my experience, I've seen a lot of errors, no? Okay. Kasi kung na-misinterpret ka ng hyperthyroidism, bibigyan ka ng gamot, no? Okay? Pag binigyan ka ng gamot, nako, tuloy-tuloy na yan, wala na katapusan, no? Okay.
May dalawa pa ho question, Doc. From Raquel, at mabilis magpawis. Siguro itong idinagdag ho niya siguro ito kung yung symptom.
Yeah, sweating.
Mabilis magpawis.
Tama. Sweating. It's a sign of hypermetabolism. Okay. Pero again, specific din yan. You have to correlate. Kasi maraming taong mabilis mapawis din pero hindi man malaking leeg. Pero tingnan mo kay Paterno, malaking leeg niya. Kaya pwede na yung pawis niya is part of it.
Okay. From Christy Sara, good afternoon, Doc Joson. Ang thyroid po ba nakakaapekto sa function ng paa at binti?
Pwede. Anything is possible. In what? But you start, paano ba yun? Theoretically, pwede. Kung hypothyroid ka, medyo palagi kang pagod, di ba? Kung hypothyroid ka, kasi wala kang energy. So, in a way, it will affect your feet, di ba? Okay? So, but it all depends on ano ba yung problema sa feet mo, sa paa mo, di ba? Yan ang tanong, di ba? What will be the nature of the problem? No? Okay. So anong meron ka bang follow-up questions? Ano bang specific?
Wala na hong follow-up question.
Diba gusto niya sagutin, ano ba yung problema sa paa niya that kung may connection sa thyroid.
Doktor, di ba nakita po ninyo yung nanay ko? Kasi minsan po lagi pong parang namamanas yung paa niya at saka lagi niya dinadaing na laging sumasakit yung binti at saka paa po niya.
May thyroid siya?
Yes po, natingnan niya siya, doktor. Nakita na po niya siya.
Okay. Kadalasan wala. Usually wala, no? Okay. Kung normal yung thyroid niya, hormones niya, usually wala. So it could be ibang causes. Ibang causes yung problema niya. No?
Hindi naman po. Kaya lang yung leeg po niya talaga malaki po yung... Di ba sinabi po niyo na dapat operahan. Ayaw naman po niya kasi natatakot po.
Kaya nga, okay. Number one, hindi ko naman masyadong matandaan. Pero number two, if I try to recall, MCAG yata yung bukol niya, di ba? MCAG.
Yes po.
Okay. Kung MCAG, normal lang secretions ng thyroid hormones niya. No? Okay.
Okay.
Hindi siya hyper, hindi siya hypo. Na? Ano? Okay. Bukol, mga bukol problem yan. Na? Okay.
Okay. Thank you po.
May question po kay Phoebe Hipos.
Okay.
Good afternoon, Doc. Can one feel secretion of hormones sa goiter? Thank you.
And can one feel the secretions?
Secretion of
Hindi mo,
hormones.
hindi mo mafe-feel yung flow ng tube ng fluid, no? Ang mafe-feel mo lang yung symptoms. Okay?
Oh, kasi Doc, parang lagi ako may yung fluid dito na malapot.
Fluid or phlegma?
Parang plema, hindi naman plema. O siguro parang plema na rin.
Okay.
Pero wala akong sipon.
Okay. So basta yung tanong mo sa akin, yung fluid, parang dugo mo yan, hindi mo nafe-feel yung agos ng dugo sa katawan mo. Di ba? Okay. So baka meron kang baka may phlegma, no? Okay. So ibang usapan na 'yon. Maraming phlegma, gano'n.
Wala, nagkaka-x-ray ko ng Doc, wala naman eh. Clear naman.
Hindi mo, yung phlegma hindi ini-x-ray 'yun.
Kasi sa lungs, baka kako sa lungs, mayroon akong
Kaya mag-attend ka rito para malaman kasi phlegma, hindi ini-x-ray yung phlegma. Kasi kung marami kayong iniisip, marami kayong papagawa.
Okay.
Okay. So basta yung thyroid mo hindi malaki.
Ay, hindi po, Doc.
Okay na. Okay na, huwag ka na mag-alala. Basta abangan mo na kung sakaling bigyan ka ng sakit ng GAD.
Wag naman, Doc. Yung ang sa breast ko nga, Doc eh.
Challenge sa'yo kung minsan bibigyan ka ng challenge. Diba? Okay, we don't know kasi as I said, we don't know when we are going to get a disease anywhere, not only
Yes, Doc.
thyroid, no? So it's nice to know ano yung possible, anong possible para alam you know how to take care of yourself, no?
Yes, Doc.
Okay?
Doc,
Any-
isa pa.
Thank
Doc,
you.
isa pa.
Okay, isa.
Bakit pag may mga time na hirap talaga akong makatulog. Minsan 2:30 na in the morning, hindi pa rin ako makatulog. Kahit pilitin ko nakahiga na ako matagal. May kaya yun?
Yung di makatulog, maraming causes yan eh, di ba? So you really have to identify, but I don't think it's due to the thyroid, no?
It's not due to thyroid
No, I don't think so. No? Okay.
or
So,
sa coffee.
okay. Any more?